Welcome guys to this video based discussion of a recent module which we are going on currently with arthropathy related to systemic diseases, and today we'll focus on hemophilic arthropathy. It has been designed in a fashion so that completion of MCQ will lead to completion of the topic proper from the very set. Alright, so moving to the topic. So what is hemophilic arthropathy? That is the thing you need to know. So before knowing into this, let's deep dive into the topic. What is hemophilia actually? So what is hemophilia? So hemophilia is a hereditary hereditary disorder of bleeding. So whenever you hear the term hereditary, thing that needs to be come in mind whether it is X-linked or the disease is autosomal. That is, you need to differentiate, right? And once you know the difference, next thing you need to differentiate whether it is recessive or whether it is dominant. It is the two important questions you need to ask whenever you hear the term hereditary. Here, the cases are X-linked recessive disorder. So, what is the usual presentation before going deep into the topic? We know X-linked recessive disorder, female will be carrier and male will be affected. Plus, as it is a hereditary disorder, so presentation will be early, very early from childhood even. Okay, so hemophilia, for now, remember it to have two types, type A and type B. Type A is due to deficiency of the clotting factor 8, whereas type B is due to deficiency of clotting factor 9. Type B is also known as Christmas disease. Okay, so that is basic understanding. Type B is also known as Christmas disease. Type A is factor D deficiency. Remember, type A hemophilia is the most common, accounting for about 85% cases of the hemophilia that is seen. Okay, so type A is factor D deficiency, 85% of case. The hallmark of this disease, this hallmark of the disease is nothing but prolonged bleeding. Prolonged bleeding where? In multiple places. It can be into the joints, into the muscles or soft tissues. Frequency and severity of the disease completely depends on the amount of clotting factor present. Suppose clotting factor is bare minimum absolutely zero, severity will be more. That's all you need to know. Okay, so what is it hemophilia? Hemophilia is a X-linked recessive disease. Males are mainly affected. Early childhood presentation. There is presentation due to joint bleeding or bleeding to the multiple places like in the muscle spaces, cavities, or into the soft tissues, right? Which all leads to musculoskeletal syndrome that we will learn into this topic of hemophilic arthropathy. Okay, all right. So moving into the first MCQ for today. So what does it says? It says a 3-year-old boy with a known history of hemophilia A presents with acute swelling, warmth, and pain in the right knee. The joint is held in flexion and movement is restricted. What is the most likely diagnosis? So nothing but it is a presentation which is the classical presentation of acute hemarthrosis, that is bleeding into the joint spaces. Now, as you can see, it has been described as a 3-year-old boy. So what is why boy? Because it is a X-linked recessive and it is young. Why 3 years? Because remember when the boy will start learn to walk, start learn to run, only when it will have fall. And there will be fall, there will be trivial trauma, and trivial trauma usually doesn't lead to bleeding into the joint spaces, but when there is ongoing illness like hemophilia, there is high chances of bleeding to joint cavity, right? Okay, so this is not your average arthritis per se. This arthropathy is not like average arthritis. This is the inflammatory destruction without the infection, right? Okay, so it is not only particular to hemophilia A, it can be seen in hemophilia B as well. Okay, all right. So this answer is acute hemarthrosis. Now, this acute hemarthrosis can have recurrent presentation. Bleed can go in again and again and again, ultimately leading to stage of synovial hypertrophy and permanent damage to the tissue. Now, as you can see, there is defect in factor 8 or factor 9, which is part of the intrinsic pathway of coagulation cascade, which leads to ultimately formation of blood clot. Right? Remember, joint bleeding doesn't occur in other diseases of the coagulation cascade. It doesn't happen in von Willebrand diseases, doesn't happen in warfarin toxicity, or even joint bleed is not seen in case of thrombocytopenia. Hemarthrosis is something very unique to factor deficiency of factor 8 and factor 9, and the treatment is very simple. Just replace the joint. Replace the joint with the factors, the body with the factors when there is deficient, and replace it fast. Right? Correct. Okay. So coming to the next question, which of the following joint is the most frequently affected? Remember, knee, ankle, and elbow are the top three joints which is involved, and the order can be remembered like knee is the most common, followed by ankle, followed by elbow, then shoulder and hip. It is the correct frequency in order of involvement of the joint. Most common is the knee, followed by ankle and the elbow. Ankle arthropathy is very much uncommon for osteoarthritis, right? So, if you see a case of ankle arthropathy in a patient of 20 to 25-year-old early age, arthropathy, chronic arthritis changes, it should ring a bell in your mind that it can be whether hemophilic arthropathy or not. Okay, so most common is knee. Remember, this hemophilic arthropathy, one of the important differential will be septic arthritis any day. As in septic arthritis, there will be similar pain pattern, but however, temperature will not rise like septic arthritis. Septic arthritis will have high grade fever. High grade fever, like something more than 38 degrees centigrade, even along with chills. Although low grade fever can be seen in hemophilic arthropathy, but high grade fever like septic arthritis is not seen. Okay, so what is the changes that is seen at the joint level in acute hemarthrosis? So suppose this is our joint. First of all, there is bleeding in the joint cavity. Now, this synovium, there is synovium encapsulating the joint space, right? So this blood in the joint space will stay in liquid form. Question is why? Because number 1 point, there is absence of clotting factor, which doesn't lead to the development of the coagulation cascade. Number 2 point, this synovium which encloses the joint cavity lacks tissue from the plastic. Due to these two reasons, this blood present in the joint cavity stays in liquid form, and liquid form it results into swelling, right? It is said that this blood is reabsorbed over 1 week, and joint functioning, that is range of motion, proper functioning of the joint, is regained within 2 weeks. However, this is all rough estimate. Actual duration of disease progression and prognosis totally depends on the condition of the joint, condition of the patient, and amount of clotting factor, that is the severity of the hemophilic arthropathy, right? Okay. So moving to the next question, here it says a 10-year-old boy with hemophilia B develops recurrent hemarthrosis in his left elbow. Over time, the joint remains chronically swollen with limited extension. So this is a case of description of chronic hemophilic arthropathy or chronic hemophilic arthritis, right? Chronic hemophilic arthropathy. What are the changes that is seen? Remember, when there is recurrent bleeding in the joint, it leads to chronic fibrosis. Now, over time, joints been through too many bleeds, it is just not swollen this time. So, this joint that we discussed earlier is not just swollen, rather it will start deforming. Sometimes stiffness of the joint will take place, and so much stiff that only medical management will not have, synovectomy or surgical correction will be required. So here the joint remains in a swollen or permanent flexion deformity or even restricted range of motion. So it remains swollen permanently, number 1 point. Number 1 point, permanent swelling. What will happen if there is permanent swelling? Joint will stay in the flexion deformity. Why flexion deformity? In flexion deformity, joint space enlarges, there is less pain. So patient will have habit of keeping in the flexion posture for prolonged period, which will in turn lead to flexion deformity. This will lead to restriction of range of motion, and later period this joint may get subluxated. Okay, later in period there can be joint subluxation. So these are the 4 points regarding chronic hemophilic arthropathy. What are those? Permanent swelling, number 1, flexion deformity, number 2, decreased range of motion, number 3, and joint subluxation, number 4. Okay. So coming to the next question, a 25-year male with severe hemophilia A present with acute hip pain and flexion posture and preserved rotation. Clearly observe the term preserved rotation, right? That is the part most of the student keeps on doing mistake again and again. So remember, in hemophilic arthropathy, there is no need, no point of the joint will keep preserved rotation. That rotation will obviously get hampered because there is swelling in the joint. Obviously, range of motion in every form of motion that the joint can do will be hampered. Therefore, rotation will be hampered in it. Therefore, there is hip pain not due to joint involvement but due to something else. So it is not due to hemarthrosis, but later on a late complication of hemophilia when the hemophilia is severe, as have been completely mentioned here, that is bleeding into the muscle space. Bleeding into the muscle space is ileoceous hematoma. And how do you differentiate ileoceous hematoma versus hemarthrosis? In ileoceous hematoma, it will have similar acute pain, similar flexion posture, but rotation will be preserved. All right. Okay. So this ileoceous hematoma sometimes can present with femoral nerve palsy features as well as. Okay. So talking of this, let's move into the proper topic of what are the complication of hemophilic arthropathy other than arthropathy related, that is osteoarthritis related changes. So number 1, it can have ileoceous bleed, which is musculoskeletal manifestation. There will be hip held in flexion and pain will be on extension. Rotation of hip will be preserved. Very, very important point, a star point to remember, but it may cause femoral nerve palsy, right? There can be chances of compartment syndrome. Why compartment syndrome occurs? Because bleeding in the enclosed facial compartment, for example, in the volar compartment, the forearm, or in the calf, which can lead to neuropathy, ischemia, or deformity, right? It can lead to permanent nerve damages. Then, if their bleeding occurs in periosteum, it can lead to pseudotumor formation. This pseudotumor is very much painful, right? This encapsulated collection of blood in the bone or soft tissue is seen. It is seen in children mainly in the elbow or the knee joint, or in adult mainly in the femur or pelvis, right? So when this pseudotumor enlarges, it causes the pressure effect, and when there is pressure effect, when there is severe pain, only it becomes the indication of surgery. Sometimes blood can accumulate in the muscle space, resulting in the muscle space cyst. Remember, there is no need of aspiration of the muscle cyst, because if you aspirate the muscle cyst, it will increase the chance of bleeding. However, if the muscle cyst gets infected, why infected? Because blood is a good culture media, so bacteria easily comes to there because they love blood to grow in the blood, and there is high chance of infection into the cyst. And if this cyst get infection, we need to go for incision or irrigation and drainage. All right. Okay. So moving to the next question. A patient with hemophilia develops painful expanding mass in the thigh. Imaging reveals periosteal reaction with bone erosion. So, it is description of the pseudotumor. What is the most appropriate next step? So, remember, in case of pseudotumor, we don't need to go for surgery immediately unless it is for late stage. So, immediate management is like of hemophilia only. What you need to give? You need to give analgesic and you need to replace the factor. That's all. That's all enough for managing, right? So, surgery is reserved only for refractory cases. In analgesia, remember, don't go for a non-selective NSAIDs that are called selective NSAID, more of a COX-2 inhibitor. So, selective NSAIDs are preferred. Okay, all right. Why non-selective is not preferred? Because non-selective hampers with platelet function, which may again lead to increase the chance of bleeding. Now, a 30-year-old male with hemophilia present with acute knee swelling and fever. Look, fever is high grade. So what is the most critical next step? So as it is a high grade fever, there is high chance of septic arthritis. If there is chance of septic arthritis, we need to go for joint aspiration. But remember, as it is a case with background of hemophilia, before putting needle inside, obviously go for factor replacement. And after factor replacement, joint aspiration should be done to rule out what kind of organism is there and what kind of antibiotic we need to go for. Alright? Okay, so coming to the topic, how to differentiate septic arthritis by hemarthrosis, or what are the clinical features of them. Remember, septic arthritis will have high grade fever, whereas hemarthrosis will have absent fever or low grade fever. Warmth is a common point for both, as it is present in septic arthritis as well as hemarthrosis as well. Tenderness will be more of a severe variety in case of sepsis, whereas hemarthrosis will have moderate grade. Synovial fluid will be completely bloody, right? And pus-filled synovial fluid will be seen in septic arthritis. Now, most importantly, a patient can have both hemarthrosis as well as septic arthritis. Secondly, joint aspiration should be avoided in such cases, and if at all done, should be done after factor replacement. Okay. So, coming to next question. Which radiographic finding is characteristic of late stage hemophilic arthropathy? So, coming to the radiological finding, remember early finding is capsule distension along with juxta-articular, that is near the joint space. There will be osteopenia. Why capsule distension? Because swelling due to blood accumulation. So, this is the first finding. Second is the juxta-articular osteopenia. All of those are early finding. What happens in the late stage? Late stage, there will be cyst formation. What kind of cyst? It is subchondral cyst, and there will be narrowing of the joint spaces. Narrowing of the joint spaces because extensive fibrosis sets in. Narrowing of joint spaces and excessive fibrosis sets in, and there can be bony overgrowth like osteophyte present. Okay, so all of those are late finding. So periarticular osteopenia is early finding. Joint space widening or capsule distension is the first finding, early finding. Subchondral sclerosis and bony overgrowth is late finding. All right. Okay. Now coming to next question. Before that, look into the changes of the normal joint plus hemophilic arthropathy. There will be cartilage degeneration, neovascularization, synovial inflammation, hyperplasia, osteophyte formation, subchondral cyst, epiphyseal enlargement, and osteoporosis. Okay. Even you can see tibiotalar joint here. Tibiotalar joint space is absolutely not visible. Therefore, this is more of a late presentation. Late presentation when there is already chronic fibrotic stage. Okay. So remember, osteoarthritis at ankle is not so common. So if there is ankle osteoarthritis, it should ring in your bell in your mind that whether it is case of hemophilic arthropathy or not. All right. Now, what is the first line treatment for acute hemolysis in hemophilia? So, as we have already discussed, treatment is nothing but factor replacement. That is option B, immediate factor replacement, factor 8 and factor 9 replacement. And it is critical to stop bleeding and minimize the joint damage. Now, other thing beside this involves is to give rest to the joint. How to give rest? With posture of forced extension. This actually helps to prevent contracture related to damage. And thirdly, we need to give analgesic. Analgesic, remember to give selective NSAIDs. Selective NSAIDs, because non-selective NSAIDs impairs platelet function. Use COX-2 inhibitors. COX-2 inhibitor like celecoxib. Okay, it is used. Now, physical therapy is not done at very early stage in the acute stage, although it is preferred when adequate analgesia has been achieved and factor replacement has been done. So, physical therapy once analgesia is achieved. So, what is the treatment modality? Number 1, factor replacement. Number 2, rest in post extension. Number 3, analgesia with selective NSAIDs. Number 4, physical therapy. A patient with hemophilia and recurrent knee hemarthrosis fails conservative management, which intervention reduces bleeding episode but may cause stiffness. So remember, in case of chronic arthropathy, treatment modality is only surgical correction or radiological correction of synovectomy. So we have synovectomy. Synovectomy is indicated for chronic synovitis. It can be open or arthroscopic guided or radio synovectomy. Now, this is obviously, as the name goes, radiosynectomy will be less invasive, but issue will have that it will have high cost and expertise is required for radiosynectomy. It is done with yttrium 90 or phosphorus 31 colloid, and it is safer, relatively safer and less invasive approach. Open or arthroscopic approach is very common, less cost, but obviously, as we are cutting into the joint, there is risk for bleeding because it is a case of hemophilia, and there is reduced range of motion improvement. All right. If there is very severe case when synovectomy doesn't help, next, that is when there is synovial membrane severe destruction, severe joint destruction. In such cases, joint replacement is indicated. All right. Okay. So here there is recurrent knee hemarthrosis. Conservative management has failed. So that is factor replacement has failed. Which intervention reduces bleeding episodes but may cause stiffness. Stiffness will be seen in open or arthroscopic one. All right, open and arthroscopic one because there is reduced range of motion. So open surgical synovectomy. Okay. All right. Which analgesics should be avoided in hemophilic arthropathy due to anti-platelet effect? So we will not prefer non-selective NSAIDs. Opioids can be easily given. Paracetamol can be given. Celecoxib is selective NSAID, so it is COX-2 inhibitor. It can also be given. We can give ibuprofen, which is non-selective. All right. Okay. So that's all about discussion about hemophilic arthropathy, right? Okay.